You're very welcome. Can you see my slides, everybody?
Yes, we can.
Great. All right. Well, then we'll go ahead and get started. Here are my disclosures. Whoops, if I can get this to go here. None of which really affect this particular talk. So if we're going to talk about ECMO for cancer and during transplant and that sort of thing, so what is the experience? And so, this is an article that's quite old now, but you can see back in this time period between 1994 and 2007, the overall survival of patients with cancer, and some of them had hematologic disease and some had solid tumor, was about only about 42%, 48% mortality. And you can see that there was a huge decrement in terms of getting off ECMO versus getting out of the hospital, which is still an issue. But overall hospital survival in this period was about 35%. And there's a lot of new articles out there. I'm only going to mention a few. This is a relatively new article from last year in which the Pediatric Health Information System, which is a big academic database here in the United States, they just looked at the occurrence of cancer patients being transferred to the ICU and found that, lo and behold, about 16% of patients who enter the hospital with cancer end up in the ICU. And that number seems to be increasing over the last few years. However, if you look at the mortality rate of patients, not just ECMO patients, but just ICU patients getting out of the hospital, it has decreased somewhat to only about overall hospital survival. That is, everybody that comes on the hospital, not just the ICU, is only about 7.5%. What they also found was even though ECMO is used relatively very infrequently, less than 1% of all the patients that come into the hospital with cancer, you can see, at least in this database, the incidence of ECMO use in this time period between 20 and 21 has increased quite a bit. And that's also been noted. This is an article looking at the ELSO database, in which they found about 900 patients in this period between 2000 and 2020. But the vast majority of these patients have come in the last decade. And again, if you just look at patients that are requiring ECMO, at least in this database, 62% of the patients had mortality overall. And certainly the other thing that was noted is that more patients seem to have been going on ECMO either with cardiac dysfunction or actually with cardiac arrest. 31% of the patients entered into the ELSO registry had cardiac arrest, which seems kind of odd because I have to say that, we try to avoid having to put patients on with cardiac arrest. We try and get them a little bit earlier than that, but certainly that was not true in this particular report. Now, probably the latest report that's come around is from about a year ago in Peds Critical Care, in which they looked at 16 PICUs that happened to respond in the US and Israel. They had about 149 patients. 118 of them were oncology patients. You can see that about 30 of them had transplants. And you can see here the indications: respiratory failure, combined cardiac and respiratory failure, and then overt respiratory or cardiac failure only in about a quarter of the patients. And interestingly, when they looked at a lot of different parameters for these patients, what they found was certainly there was no association with the amount of packed red cells or platelets the patients had received, which has been noted as a risk factor for ECMO patients just in general. They also found that there was no association with whether or not you receive VA ECMO versus VV ECMO, although in patients that had to be converted from VV to VA ECMO, those patients did very poorly. And actually, I think 6 of the 9 patients that required conversion actually had a cardiac arrest on ECMO, which is relatively uncommon. But certainly if you're doing veno-venous ECMO, one of the things you do have to watch out for is they can go into very acute right heart failure, and that can lead to cardiac arrest. So be watching for that. There was also no association with the diagnosis of the patient or whether or not they needed a transplant or not, an ultimate outcome. And there was no association of using severity of injury scores, such as the oxygenation index or the vasoactive index, with ultimate outcome as well. And when we just look very closely at transplant patients, those patients that had allogeneic survival had about 23% survival versus autologous transplant patients with about 55% survival. Interestingly, in this particular data collection, whether the patients received CRT or not, patients who received CRT was associated with lower mortality. And you were not able to identify in this data set whether the CRT was just for fluid removal or overt kidney injury. But interestingly, CRT, which has been associated with higher mortality in a lot of studies, was not true in this particular patient population. And if we look at the incidence of ECMO runs and survival per year, so here are the runs, here is the survival. You can see, the runs have sort of been up and down, but if you were to put a trend line here, they have been increasing. And the survival overall really has been between 40 and 60%, which really, uh, you know, uh, is not that bad when you consider that respiratory failure patients in the pediatric population have an overall survival of about 60%. So doing these patients is really not completely crazy. And when you look at bleeding complications and some of the other complications, here you can see, as opposed to other registry children without ECMO, as opposed to cancer patients, they did have more hemorrhagic site bleeding. They did have more incidence of DIC. They did have more problems in terms of intracranial hemorrhage, which you have to watch out for. Whether that's related to platelet counts or whatever is not really clear, but just to watch out for that, because certainly a higher incidence of that in patients with cancer. And if you look down here at some of the other complications that they had, again, there was a much higher use of hemofiltration and dialysis actually in the cancer patients than in the other patients within the ELSO registry. And there was a little bit of an increase in the need for inotropes, as well as patients with hypertension who required some type of vasodilatation. So they do have some increase in complications. How those factor into survival isn't really clear. If you look here just in terms of more specific information about patients who receive transplant versus not transplant. And again, these numbers are all very small, but you can see here that in terms of, the p-values for any of these things, there really isn't any of these particular parameters that were significant between the patients who had an oncologic diagnosis who did not receive a transplant and those that did receive a transplant, which is, I think, something that is of interest. The only thing that was important is that potentially the oncology patients without a transplant had more incidence of thrombosis than the patients who received a stem cell transplant. And if you look a little bit more closely at the different diagnoses, these patients and indications for ECMO that they came in with, again, you can see that in almost every case, except for those with hypercarbia, there is still this gap between they get off ECMO, but they don't make it out of the hospital. And certainly this is something that we're trying to figure out, is this recurrent disease that happens or ongoing complications that are manifested after they get off ECMO? But certainly this is fairly disappointing if you're an ECMO doctor. You get these guys off ECMO and then they still don't make it out of the hospital, but their survival in the ECMO period is actually still, again, about 40 to 60%. And if we look at oncologic versus non-oncologic diagnoses, you can see here again, oncologic diagnosis for ECMO survival and hospital survival. Here's the stem cell patients that we had. And then again, if you had a stem cell transplant for non-oncologic reasons, which is happening more and more often now for sickle cell disease and other things, you can see that those patients probably had the best survival out of all of the groups. And that has been repeated by others. The other thing I want to mention here, which was mentioned in this article and has been mentioned in a variety of other critical care settings, is that variability in outcomes still exists between centers. And I do think this is one thing that we can work on together. This has been shown in some work I've done in terms of ECMO patients, pediatric ECMO patients in the past, and lots of other scenarios as well. But you can see here that patients, there is a lot of variability between the centers who have submitted patients in this article and hospital survival. And certainly the ones who did it more had better outcomes than the one that did it less. And certainly one of the reasons that I've started this new company which provides supervision remotely for centers is to try and help centers who may have a little experience or who need, just some expert help or something, give them somebody to call and talk to. And I think that's something we can work on in the future. I mentioned that the oxygenation index and the vasoactive score did not seem to have any association with outcome, even though, if you look at the oxygenation index and you're a believer that 40 is a very high number, which I am actually, you can see here that these patients are all pretty sick. None of us really seem to have accepted the fact that even at an OI of 18 to 20, it's been shown that your mortality triples. Still, we're beating these kids pretty hard. You remember the oxygenation index is determined by your mean airway pressure times the amount of oxygen that you're on divided by your PO2. And certainly these are pretty high vasoactive scores as well. So all these patients, are pretty sick when we put them on. But again, none of these things in and of themselves were predictive of outcome. When they did look at what was predictive of outcome, again, really none of these things really stood out. Whether or not you had CPR, that was a bad thing. Again, if you had CRT, that was protective for some reason. And if you looked at hospital mortality, again, except for CPR and the need for converting from VV to VA ECMO, none of the things that you think might be important in terms of outcome really were associated with survival out the door. And again, just looking at modes of ECMO, as I mentioned, really no difference in terms of VV or VA unless you were converted from VV to VA, and then that was necessarily not a great thing for you. And if you looked at the type of cancer that people had, again, no association with type of cancers too much, although this is like an N of 0. But you can see these are all pretty small numbers. But ALL, certainly something that we do much better with than we did 20 years ago. T-cell disease, lymphoma, AML, solid tumors, non-CNS solid tumors, etc. You can see here the survival of these things. And I think even though these are small numbers, it does give you some ability to counsel the families a little bit about what they can expect. And certainly we all say that cancer patients have less good outcome than non-cancer patients. But really, if you look at the statistics, it's not that much worse than our average patients. The other thing that we always worry about is what happens to their platelet counts and their hemoglobin. And so this is just sort of data showing that their platelet counts, at least in these patients, were between probably 80 and 100,000 in the first week of ECMO. You can see people were keeping their hemoglobin relatively high, not something I believe in, actually. But you can just see the trends there in terms of how these patients were cared for. And if we look at the era of when ECMO was done, you can see, interestingly, that if you look in the pre-2015 versus the post-2015 era, you can see the survival has actually gone down. And why is that? Well, I think one of the explanations is there was a lot more cardiac patients placed in this era, and there was more patients who were receiving CPR or had received CPR at some point in time. And if you looked at the stem cell patients, though, you can see that the survival is about the same. 64% of them are actually getting off ECMO, about a third of them making out the door. And when you look at parameters such as white count, neutrophil count, platelet count, again, these are the averages of these patients. So about 65,000 is what these patients have. And one thing I think I've learned over time is If the platelets are low and you give platelet transfusions and they don't go up, just stop, because it doesn't seem to me like they tend to bleed all that much, even if their levels are, 25 or 30,000. And rather than giving more and more platelets, which are ineffective, we know that increased platelet count really may not be a marker of good outcome. So in summary for this part here, patients with oncologic diagnosis or those who receive transplant do have potentially a higher mortality than pediatric patients who don't have these diagnoses, but actually they do pretty well. About 50% at least get them off ECMO. If you get them on CPR, that's not a good thing. None of the patients who developed cardiac arrest on ECMO survived a hospital discharge, even though it was a small group. And certainly, has been mentioned even in the last talk, these patients are very complicated and really require a lot of multidisciplinary discussion before you put them on. What is their chance of ultimate survival, et cetera, and ongoing, okay, how are they doing? How long are you going to keep them on? That sort of thing. One thing I didn't mention is that even for patients who have acute diagnoses, those patients have also been successfully supported with ECMO. They've gotten their chemotherapy. They can go into remission on ECMO, that sort of thing. So don't be afraid of that anymore, because that has been done. That used to be a fear in the future. But what I wanted to sort of end up with was talking about this consensus statement, which came out not that long ago. And this is in response to the fact that there is more ECMO being done in patients with stem cell transplant, and as CAR therapy, CAR T-cell therapy, and other things are coming down the pike. Those patients are also being placed on ECMO with more frequency. And so this group of, experts, if you want to call them that, international multidisciplinary folks got together and they came up with recommendations. And so everybody believes in multidisciplinary evaluation. But if we go through in specific some of these recommendations here, you can see, if you think that the survival is likely to occur, there is very strong agreement that that is a good candidate for a patient. In children receiving stem cell transplants for non-malignant disease, aplastic anemia, SCIDs or whatever, sickle cell disease, all that stuff, really these kids tend to do quite well, and there was very strong agreement you should consider them. If you have refractory thrombocytopenia, again, people are nervous about that in terms of whether or not you should put those patients on, but certainly not an absolute contraindication. Certainly, if you've had repetitive bone marrow transplants and you keep having the same disease, people didn't really think that was a good idea. And certainly, if there was a less than 30% chance of survival at 1 year, not too many people believed in that either. And I don't need to read all this to you, but certainly you can see here that, the underlying primary disease, the current critical diagnosis, is it likely to be short-lived or not? How many numbers of injured organs other than the heart and the lung are important, all of those things. And certainly the patients and families' care goals are really important to look at as well. And if you look at patients with either graft function problems or specific complications from their stem cell transplant, you can see here, a lot of this is there's not enough data to really give you strong agreement. But these things, I think, can help guide conversations, especially in patients who are getting transplant, because at least you can say there is a consensus statement out there that either provides some guidance for you or not. And certainly one of the things that has been very important is how bad your GVHD is. If you have really bad GVHD, patients have not done so well then, unless you have, bronchiectasis or the bronchial blood is obliterans here, who may be candidates for lung transplant as a way out from that particular complication. And if you see patients who are getting CAR therapy and that sort of thing, again, these patients, even though there's a relatively small group of them, have done quite well in terms of how these patients do. And then just, echoing other people's opinion, you really need multidisciplinary interaction for these patients. And certainly we need more data. So more registry data for these patients is going to help us, I think, in the future. And so the key messages from what these guys said is that, T cell therapy, stem cells therapy have been associated with improvements in survival. You need a multidisciplinary team. Certainly, recovery from their critical illness is very important as well. And certainly, earlier on, or the longer out you are from your transplant, the better off you tend to do because you've been grafted by then. Really quickly, I just wanted to mention that we have come up with some new recommendations in terms about how to care for the lung. This is not specific for cancer patients, but just really important stuff to follow. Again, looking at the OI, PF ratio, and that sort of thing can give you some idea of how sick the patients are. And I was part of the group that looked at ECMO. And certainly we have no strict criteria, but we do believe that if you use serial evaluations of the OI, PF ratio, that sort of thing, it may be helpful. VV ECMO, if you can use it, avoid hyperoxia, slow changes in PCO2, as was mentioned before, and certainly using lung protective ventilation while you're on ECMO are recommended. And here are some of the recommendations in terms of what you go for in terms of when you're on ECMO, what are the lung protective things that you should be looking for to help protect the lung during your care. And I won't mention this too much, except to say that this is a study that looked at adherence to the pediatric ideas of lung protective ventilation. And what they found was that we don't do it very well. We use lower PEEP than recommended 70% of the time. We didn't follow the tidal volume rules very well. Delta P was higher than 15, which is what the recommended level is at all levels. So just pay attention to what you're doing. And it's interestingly, in this particular multi-center study, having respiratory therapists involved in the vent management did seem to be helpful. And so I'll skip all this stuff. So the final thoughts here are that malignancy and transplant, the use of ECMO is growing. Outcomes really haven't improved markedly, but really, I mean, not so bad. Center variability affects outcome. There isn't enough data being recorded, and certainly global collaboration is really needed. And I encourage you to participate in those efforts as much as you're able to. And I'll end there by saying thank you very much for inviting me to speak.